My name is Paul Garcia. Just to give you a little bit of background about me, I'm an internist. I did internal medicine, and I did a fellowship in geriatric medicine, which was a 2-year fellowship. I'm also boarded in hospice and palliative care, and also hold, if you notice the letters, a CMD. That's a certified medical director. There's a large organization called AMDA, and they're very involved in long-term care, making sure the regulations, making sure patients' families are getting seen, and just making sure that the doctors are up to snuff as far as taking care of your loved ones. So the CMD actually does mean that these physicians have taken additional training in taking care of patients that live in long-term care. Today I'm going to be speaking about long-term care, but before we even get started, every geriatric topic or talk begins with some of the demographics in geriatrics. So we're going to get started here. I did write down the objectives that I'd like to get done today, and that's review the demographics, go over the types of care just in general out in the community before you get to long-term care. Also that transition to long-term care, some of the what I consider the do and don'ts in long-term care as far as family members and even the physicians, and then we've left some time for question and answers. So just to look at the numbers. As everybody knows, and I'm one of them, the boomers are coming. And actually they're already here. And some of you don't realize some of the first boomers, these are the people that were born after World War II in 1946, and some of the notable celebrities and heads of states are President Bill Clinton, George W. Bush, Steven Spielberg, and they're at that age now where they're considered, I guess, seniors. If you look at just the demographics, in 2030, it's projected that 21% of the population will be over the age of 65. And if you look at now, we're at 12%. And then also, if you look at just the healthcare dollars, which has been a big topic for the last couple, I guess about a year or two, about all the things that are going on in healthcare, 30% of healthcare expenditures are done by 12% of the population. That's current today. So just think about when you get to 21% and look at the healthcare dollars that will be spent at that time. Also, our model of care have changed. If you look at when Medicare first came into being in the mid-60s, Medicare was built basically for hospitalizations. A lot of times back in the early 60s, 50s, people, if you talk to some of the seniors, the hospitals were considered somewhere you went to go die. Or they didn't have health insurance, and so people didn't go to the hospital. So we've gone from an acute care model to now we're seeing chronic care. And so when I mean chronic care is you have a lot of illnesses, and we've gotten good at slowing processes down. We really haven't cured a lot of things, but we've slowed down diabetes, we've slowed down heart disease, we've slowed down cancer. So basically a lot of our care now is chronic care, and what you see is these acute exacerbations, meaning that you'll have an acute event from that disease process, you get it under control, and you keep going with things like that. Also, with our society, with everybody being spaced out, years ago, families stuck together, but now, people leave for jobs or move across the country. And if you look at the care that's being provided, it's still done by the majority as family members. So family still really is taking care of family. And then the other thing I wanted to point out is that if you look at the long-term care population, and this holds over the years, about 5% of the population over 65 resides in a long-term care facility. And you can break that down even further. It's about 4 to 8% from the 65 to 75. If you look at the majority, they're actually over 85 years old. Another number that I think that's stands out is that by the time you reach 65, there's a 40% chance that you'll spend some time in a long-term care facility, whether it be skilled care after like a knee operation or some kind of surgical procedure, because the push for care has actually been, you take care of the acute illness, move you out to the community, get you out of the hospital. And so skilled facilities, which are in long-term care facilities, so there's a 40% chance that you might spend some time in a long-term care facility. If you look at the people that are living in long-term care facilities, you see about 55% will stay for 1 year, and 21% will stay about 5 years, and then you have the rest percentages in between. We're going to go over the types of care. And this is before we get to long-term care. So the types of care that you can have for your loved one when you do reach that point where mom and dad does need care, you have home care, which can be in-home care, such as you're paying for somebody to come in. They might have Medicaid, so you have a provider. You can have a live-in, or they can live in your own home. You have senior housing, and what I mean by senior housing is that you can have just apartments that they take 55 and over. They tend to not have skilled things that you can have, like nurses going in there. It's usually going to be an outside agency that comes in there. So that's still pretty much independent living. You have assisted living, which has been a big boom. If you look at long-term care beds, they've been pretty steady, but assisted living has just taken off. And what I see in assisted living is that it does fit a niche, but the screening process a lot of times is difficult in the sense that you want to try to put your loved ones in an area that they have a lot of independence, but their care burden can be so big that they really probably need to be in a long-term care facility. And over the years, I've also noted my own patients that live in assisted living. They'll say, well, our facility used to be pretty. He had a couple people that maybe were in a wheelchair, and now everybody's in a wheelchair, or they're having a lot of patients that might have memory impairment, and they're going from door to door and lost. So I think as time goes on, that's going to become even a bigger issue. And I think that as far as assisted living, we have to do a better job of screening and also making sure we get them in the right care areas. And I think that's where it's important, where you see these places like Morningside Manor, where you have the big community, so you can age in place and you're able to kind of go through the different stages where your care can be met, and I think people know you better, so they know where you need to be at certain times in your life. Personal care homes, another option for people. And personal care homes can be anywhere from a couple of adults, 3 seniors or 4 seniors, to even up to 8 seniors living in a house. And the quality can be from not very well to excellent care. And I've had patients that were completely bedridden, had cancer, and the facility, the personal care home, took excellent care of them. So, and that's again, those are by word of mouth. There's not like a lot of times you have to just go in the community and try to find those, or try to find them by word of mouth. You have long-term care homes, or nursing homes, or you have a combination of any of the above. Also, I put on here PACE, which is a government program. We don't have a PACE where I practice, but like in San Francisco and some other communities, they have PACE projects where patients that are double their Medicare, Medicaid, and the process is to try to keep them at home as long as possible, because people do better in their own homes if you have the support. It actually costs a lot less, and so it's a combination of where they have people going in the home to help the senior take care of themselves. They might have adult daycare. They do transportation, and pretty much the government pays a set fee per month to the PACE program to take care of these seniors. And then adult daycare, I'm starting to see, especially in homes now, or freestanding adult daycares, where people that are working and they have their loved ones with them, and they'll take them to adult daycare, take them in the morning before they go to work, pick them up when they come back. And I think that's actually a good thing, because think about it. If you're kind of frail and you're left alone, I mean, you don't have that kind of stimulation that I think you should get. And I think that kind of accelerates your disease process. I think it can affect your memory. So a good adult daycare, I mean, can engage you, keep you active. You get the socialism. You get to socialize with other seniors that might have a lot in common with you. And that's not for everybody, but I think that's an option that you can try. Going back to long-term care homes, if you look at Texas, the number of homes in Texas is 1,000, over 1,000. Texas ranks second in the nation as far as the number of homes. California is number 1, and which I found surprising, Ohio was number 3. I never would have thought that. There's different types of homes. You have the for-profit, you have the non-profit, you have the mom-and-pop homes where they might have 1 home, or might have like 3 or 4 homes in a community or a state. You have the religious homes, which are in general the non-profit, and you have a combination of any of those. And my own preference, and I don't want to get any questions telling me that, you know, it's all different, but from my own experience, you know, I find the religious, the nonprofit, the mom and pop, and then the chains. I mean, they all have their good and bads, but as far as a physician that goes to the home and has a say, you know, a chain's not going to listen to me, where a mom and pop home will kind of listen to me, or we have a better working relationship. If you look at the payers, who's paying for this type of care? You have Medicare, managed care, the VA. The VA actually has their own homes, and they also contract out. And if you just look at the geriatric literature, at least in the United States, actually geriatrics came out of the VAs because they had all these World War I and World War II vets, and they had to take care of them. And so, you know, most geriatricians that trained at big programs trained in, you know, spent some time in a VA, because that's where all this body of knowledge came out of, taking care of our seniors. People can have long-term care insurance, private pay, or Medicaid, or a combination. Kind of to go over the percentage-wise, if you look at the payers, 50% is Medicaid, about 25% is out-of-pocket, 12.5% Medicare, 7.5% private insurance, and 5.6% other government. Looking at the average cost of living in a long-term care facility, $70,000. And this is from information that I looked at. It was a MetLife survey. And what kind of blew my mind was the $200,000 in Alaska. And I looked at that, and I clicked it on, and I did find a home, long-term care facility, that was close to $16,000 a month. And the lowest was Shreveport, Louisiana. And when I showed this about the difference in the cost, one of my partners said it's because they're paying for the heating bill in Alaska. So how do we determine who needs to go in a long-term care facility? And usually what happens? Well, if you look at about 50% of patients, something acute happens. You know, mom or dad was doing fine, then all of a sudden, boom, a fall, a fracture, some kind of an acute illness. So that leads to, you know, they get taken care of, but they're too weak from being in the hospital or deconditioned, so they'll end up going to a skilled facility, usually in one of the homes. And we'll see if they'll do better, and if they don't, then what do we do with mom or dad? So that's one way that you end up being placed in a long-term care facility. Another one that I see is the death of a spouse or a caregiver. A lot of times children that live away from their parents, and mom and dad have been together for a long time, and it's all of a sudden, you know, dad might die, and you realize, gosh, mom does not know anything. She has memory impairment, and it could have been hidden from the kids all along. You know, mom had the great social graces, because that's like old memory. But then you realize they can't do the bills, they get lost, and you realize we got to do something. A lot of times you see that the senior will decide. A lot of my patients will say, you know, I don't want to be a burden on my children. I don't want them to have to worry about me, so I'm going to go ahead and go to a facility so they don't have to keep worrying or coming and taking care of me. And I see that a lot. And I always kind of tell my patients, I said, you know, one of the great joys that as a child is to be able to give back to your parent, to be able to take care of them. It's not a burden. I mean, even being a doctor, my folks hate to bother me because they think that, you know, he's a doctor, I don't want to bother him. And my mom actually